SSF Spine Residents and Fellows course. We're live here from Seattle, and we have an outstanding faculty. Morning, everybody. We're live in Seattle for the 11th annual Residents and Fellows course. I want to welcome all our faculty, and I want to thank our faculty who have taken the time out today on Saturday to teach the course. And obviously, because of the COVID situation, we decided to push forward and have a virtual meeting rather than cancel it. And this year we have an exciting agenda. We're trying to pack everything into one day. And we've divided it up so with each session there's a moderator, and then with each session there's also a live demo. And then obviously, just like most of you have figured out with Zoom, you know, there's like a little chat box. So if you guys have questions or comments, please put them in the chat box. We have some incredible lectures from amazing faculty. And I just want to, once again, thank all the faculty. I'm just going to quickly go through. So we've got Dr. Chapman, Dr. Hamilton, Dr. Sanser, Dr. Amir Abdul-Jabbar, Dr. Joseph Chang from Cincinnati, Richard Chua in Arizona, Dr. Gogawala in Massachusetts, Dr. Jim Harrop in Philadelphia, Dr. Patrick Johnson, who is going to join us as well from Los Angeles, but actually he's in South Carolina right now, Isaac Karakari from Duke, Dr. Kazemi from Arkansas, Dr. Koo from Los Angeles, Dr. Kim from Los Angeles, Andrew Minista, Mark Moisey, David Akakwo, Jeff Rowe, Jay Turner, Udi Mendel, Ronnie Nasser, Paul Park, Nick Theodore, and Juan Uribe, and last but not least, the fabulous Mike Wang in Miami. So this is a really special course, and we spent a lot of time putting this together, and I want to thank all the faculty again and the sponsors. We have a great agenda. We have our first lecture, and it's an honor for me to introduce Dr. Jens Chapman. We always start this meeting with his holy discussion of the 10 Commandments of spine surgery, and we're going to continue that tradition. We actually, normally we give out hoodies, and we actually have the 10 Commandments out. And last year I was able to slip a new one in, but he noticed. So Jens, thank you so much.
Thank you, Rod. My name is Jens Chapman, and the hallmark of the era of COVID I will remove as Rod is out of safe distance. This is the 11th annual Spine Residents and Fellows meeting, so welcome to this. And it seems so surreal to do this just in video, but it's also been a very cool format. It's a distinct pleasure and privilege to be here, and I mean that. If I look at this faculty roster, it's a who's who of surgery in our domain, and literally every one of those colleagues is a major, major contributor. So my contribution pales, but I see my contribution being in part, and I'll need a remote control, Lee. I don't have a remote control here. Lee, I need a remote control.
Well, Windows control.
Oh, okay.
Oh, wow. So I'll say next every time? Okay, that'll be fun. So we'll take the first slide then. We'll go real high tech. This is meant to be a thought-provoking kind of a guidance that we've always used, and it's not jokingly or anything like that. It's meant to be just a reflection on who you are and how you want to present yourself in this new era as you're going on into your career. And I hope that today's sessions will provide an inspiration by having a close-up at least digitally, of some of the superstars in the field. So that's the premise of this talk. And again, the opportunity will be there, at least digitally, through the chat room. Rod and I and the moderators will manage the chats. We will basically look at who's who. And I'm still waiting for my first slide, so that's where we're going. But I hope that you'll make use of the chat room function. We found that to be very helpful in our many weekly meetings, where we basically have one journal club, one case discussions, and our usual STED talks, the Spine Technology Education and Discovery presentations. We're very privileged also to have you here with us today, and I think the last count was, Rod, 480 participants who are all eagerly waiting for my first slide. So if you can go back to the startup slide. So this is the welcome slide, and we'll go on from there. So the basic goal of this is to make you the best spine surgeons on planet Earth. And spine is such an amazing specialty because it identifies and challenges your cognitive skills as well as your dexterity. And it also challenges your personality because setbacks are inevitable. And the NHS has actually something that I really find great. Our great friend and supporter, Michael Hutton, is the godfather of this GIRF thing, get it right the first time. And spine is so unforgiving. If you move ahead, please. Murphy's Law, which we're all familiar with, really applies to spine, and every little detail counts. So moving ahead. And again, the number 10 is one that's deeply entrenched in our culture, and again, in movies and in late night comedy. And this is what we in the AO always had is the 10 Commandments. So I've paraphrased this old 10 Commandments, which was the AO gospel, to our realms, but with a different thing. So the inspiration for this lies in the late and great John Jane and Professor Majid Sami, who are some of those greats. And I've had the privilege, again, the word comes out again, in being with some of the great surgeons of our lifetime. And there was an amazing consistency that I found that I think is underreported, that I hope that all of you will emulate. And that is an incredible calm and confidence and kindness in the operating room. There's no yelling, there's no shouting, there's no stress, there's no dysfunction, there's no instrument throwing or tantrums. It's a calm, collective, collaborative flow atmosphere. And so if you see Majid Sami here, and again, Professor John Jane, who is such a great inspiration for me and for so many of the faculty here, these were people who are just really amazingly transcendental in the influence. So these 10 commandments that are now to come are kind of taken from my observations in various compartments. Moving ahead, please. So number one, right patient, right time, on the right location, on the right side, every single time. I'll challenge you to something. In your consents, be so clear that you spell out the levels, and if you're imprecise because you don't know where, spell it out. Have the guts to just spell it out so that in your timeout, you can reiterate the exact target of your procedure, and if you're unsure, be open about it also. There's nothing wrong about that, but then spell it out. What we don't want to do anymore and what we don't need to do is Columbus surgery. That's this kind of exploring around, not really knowing where you're going, not really knowing what you're going to do and what things you'll leave behind. So no Columbus surgery. Going ahead. So this, again, means that you have preparation and a keen understanding of your patient. So let's go into number 2. So positioning, this is one of those silly little trivialities, but you know what? Everything, again, counts, as I said. So going ahead. So many of our patients are obviously very, very challenging in terms of their weight, their size, their morphology, and going ahead, yet again, you want to be the one who's in charge of every little thing. Head height, eyes, chin, throat, pressure points, imaging visibility, and biplanar things. Is that EKG lead over the target level? I can guarantee you if you don't pay attention to that, right, Rod? It will be right over where you need to be. So those are these little things. Going ahead. So yet again, preparation, thoughtfulness, and we can advance the slide. So number 3, again, don't drape yourself out. One of those silly, stupid things, but I can tell you words that I don't want to hear. So I'm looking at Rick here. He's never done that, but I don't ever want to hear those words, right? So the words are, oh, it's prepped underneath. That should never, ever happen. You should know exactly where you're cutting, and if you go to the upper thoracic spine, drape out the whole cervical spine. No compromise to that. So going ahead, Lee. So thoughtful preparation. Number 4, when you expose, you don't want to have and here comes a German word, a Schlachtfeld, a bloody mess. This is not what you want. You want to get started right. You want to move ahead to the target area in a precise, clean, concise fashion, preserving what structures you want to preserve. Especially nowadays, we as open surgeons should learn from our minimally invasive colleagues and preserve ligaments, preserve adjacent levels. That includes muscles and innervation without harming them. And moving ahead to Rule 5. The other thing is, and again, dural tears are not a big deal, but they're a big deal. They are a big deal, they're not a big deal. They're both. And they probably, if they're unintended, should be listed as a complication, because undeniably they do increase surgery time, resource utilization, length of stay, and complication risk of patients. So if you can at all during your exposure, especially avoid an unintended dural tear, that's fine. And what does this mean for you again? It means anticipation, and this is challenging your execution. This challenges your dexterity skills and just foresight. So you make a plan for your exposure, especially in the ubiquitous revision surgeries, to be very clean and clear, and leave a nice soft tissue coat around the patients, especially dorsally, so that you can have a good closure, but at the same time preserve neural elements where needed. And going to Rule 6 now. And that is, again, the kind of staying organized rule. We have so many gadgets. I mean, the minimum cables that we now have, including suction devices, are about 6 or so, and it's very easy to get those tangled. What I've seen in really good surgeons is they keep everything untangled. They are a team with their scrub tech, and when there's an entanglement starting, they ask for help to get it untangled so that everybody's on the same page. If you don't do that, you'll drop tools, you'll drop the most important thing, and I can assure you that when push comes to shove, your bipolar or your sucker will be on the ground as you really need it if you don't keep things untangled. What I've seen the masters do, again, Professor Sami, for instance, is just very calm. Please keep those disconnected. Please keep this untangled. Can you help me a little bit? The great Professor John Jane would ask, right, his back table people, keep me organized here, keep me straight. And it's done in a very calm, collaborative fashion. And number 7, so staying organized, big deal, and no mess on the table. This is the cottonoid rule. Who's not been there? Who's not seen that? You've done a great job in your surgery, and then the famous words come, right, Sven? Cottonoid count. We're missing 2 cottonoids at the end of a mega case. And your concentration is down, you want to just move on, and there's a complete stop, and you have 8 OR personnel on the ground sifting through the trash bags. You don't want to do that. This almost does not happen if you have a simple rule. Cottonoids live either in the patient, accounted for with tails, or they are on the Mayo stand. Nowhere in between. You don't drop them on the table, you don't put them into pouches. You have a complete control over tails in the patient or on the Mayo stand, and that's where they belong. And that goes for any and all of your things. You should always kind of be able to tell the nurses when they do a trade-off count, how many sponges are in the patient and what instruments there are. And this is, again, a pet peeve of mine, but it keeps the instrument table completely clean, it keeps the patient clean. You either use the tools or they're on the Mayo stand and nowhere in between. And exceptions for that are attending prerogative, right, Rod?
Absolutely.
Okay, so, but that's it. This is number 8, and again, usually we play an audio clip there of the singer Paul Simon. I know this younger generation does not know who he was, but in my generation he was very popular. But he had a famous song called Slip Sliding Away, and if you go on to the next click there, Slip Sliding Away, the nearer you're towards your destination, the more you slip sliding away. What this means is do not let down your guard. At the very end of a case, as you're seeing something going on that's really close towards perfection, and you let your guard down, that's where your instruments will slip. And the beauty and the curse of spine surgery is this very close proximity of finesse and unbelievable power tools. And it's very easy to lose control of those, and you can permanently change a patient if you slip with that power drill or that curette or something like that. Moving ahead. So this is, again, staying in control, realizing the power of the things that you use, not plunging with the pedicle finders, the curettes, or the various drills that you have, and that goes for MIS just as well as for open procedures. Number 9, and this is probably one of the most important things that I see, this is the refrigerator rule. What I mean with that, you should take absolute pride in what you do. Those final images, even if they are micro decompression, I take a spot shot in my clinic, my staff prints them out as a simple paper copy with your name on it, and patients take those home and they put them on their refrigerator. And then they say that, wow, this case that Dr. Elias did, he's the best surgeon. Look how beautiful those implants look how beautifully contoured my spine is. And that goes on to the skin incision. Your skin incision should be a beautiful closure that you're proud of. That's what people see, and that's what they're going to go around with. Nobody sometimes knows what's going on except for the x-rays, but if you have a nice, aesthetically pleasing 3 or 4 layered closure, they're going to heal better, and they're going to be proud of it. So you're going to be proud of what you're doing. Number 10, and this is the final thing, the age-old Hippocratic oath, don't harm patients. If in doubt, do less. Always kind of re-equilibrate with what you're doing, with what is in the best interest of the patient, and those are sometimes big challenges. And then finally, we'll move ahead. The mantra of spine surgery that I really like is I don't care for somebody going like, I did a half-hour decompression or something like that, or I did my ACDF in 45 minutes. That for me is baloney. It is your privilege and it is your task to take care of this patient. And when I'm asked, what is the most difficult surgery? When Dr. Price comes to me, Chapman, what's the most difficult surgery? I'm going to tell him the most difficult surgery is the next microdisc you're going to do. Because why? You need to do everything, you need to have everything together, you need to have all of those 9 preceding commandments in place to do this perfectly. And you spend the time necessary on that microdisc to make sure, because that's your best chance to make this patient really well, to do this just right. So being efficient means you're not tarding around, you're not lazing around, and you're precise, and that's the secret to success.